That's a lot of diversity there. That's more than what, that's better than how I summed it up. So I think definitely social connections, peace of mind, synergy with norm reality. That's actually, I think all of that summed up could be the perfect answer for that question.
Miranda?
Yes, I mean, I think these are a really interesting set of suggestions, and there's really some complexity here because you can have a mental health disorder diagnosed and have emotional well-being, and we want to make sure that that happens as well. And you can have poor emotional well-being and not have a mental health disorder. So I just want to be really clear what we're talking about here, because we're not trying to create perfect human beings. Well, what we want to do is to have people be able to achieve what's important to them in life, which may mean continuing with some diagnostic categories, it may not, but it is about trying to get that right balance. I guess I just thought it'd be helpful to share that.
Thanks. Anybody else? Iman, and then Anne.
I remember when we was talking with the community, we go in we are Ministry of Health, go for Ministry of Education and other ministries to talk about mental health. And every time we go there, people just go for the severe mental illness, not for well-being. Usually when we are talking about mental health, people thinking about schizophrenia, thinking about things that this is in our country, maybe because of stigma, not going for well-being, not going for that this something concern everyone, not just the people who have conditions, mental health. So I'm so happy that people here online and in the room can see this, that it's connected to everything in our life, not just for the mental health conditions.
Thank you. Craig, we're coming to you in a short while. I hear that you can hear us. And
yes,
first, and then we come to you. Thank you very much.
Thank you.
Good. Yeah, I think I just wanted to pick up on what Manvi said in terms of it being kind of a spectrum or a continuum, and that, any one of us at any given point in the day can be on a different point in that continuum. And also throughout our lives, we can be at different points in that continuum. I also really love that people on the screen or with the word cloud picked up on so many positive aspects of mental health, because mental health in and of itself is, encompassing of all of those different aspects. Including a lot of those social ones, not just individual. It's not always about just the individual. So I love that people included things like connectedness, relationships, all of the things that you would find from our mental health and well-being within our community.
Deborah.
And to add that it was somehow also mentioned, perhaps by Miranda's comments, that when we talk about mental health in this field, we also include people with mental health disorders, diagnostically disordered, and 1 in 8 in the world have a mental health disorder, and that is also included in the concept of mental health. So it's true that it's not just the most severe ones, it's not just the most common ones, it is also the well-being, but it's everything. And if we focus only on the positive side and the well-being, the risk is that we keep forgetting those who need attention or care and don't get it. So it's a comprehensive field that we deal with.
Yeah, I think what we heard is very clear. We see the continuum, but I think, as Miranda said, the discussion now will zoom in a little bit into more the mental health issues and conditions rather than the broader well-being spectrum. Now, Craig, over to you. If you can just catch up and introduce yourself with 2 to 3 key features, and also include why you're passionate about engaging in youth mental health. And if you want to comment on that Slido, be welcome. Over to you.
Great. Thank you so much, Alexander. Can you hear me?
Yes.
Okay, wonderful. So just to say, the bit that I've been hearing really resonates a lot with my own understanding. For me, mental health is really about the capacity, especially the emotional, the cognitive, and the behavioral capacity to lead the life that one values and one chooses. And I think there's a lot captured in here that reflects that. I also really subscribe to the idea of mental health being on a continuum, and we all, during the course of our lives, move up and down that continuum depending on the social and economic circumstances we face from day to day. And I think that's also reflected here quite a bit. The reason that I'm passionate about mental health is that I think it allows us to think about and address a whole host of other development policy priorities. For example, education, employment, gender-based violence, poverty. These are all intertwined with mental health, and by addressing mental health and putting mental health front and center, I think we have an interesting and I think neglected perspective, which we really should be pursuing in terms of broader development policy. Thanks very much.
Thanks, Craig. So I think we're kicked off with that first round and would now come to the first block around the challenges. And Deborah, the first question would go to you in terms of your global mental health report has just been published in June, and you've done extensive, literature research. You, as WHO, you have a wide reach into member states and know quite well the different situations. So what are, in your view, the key challenges in the health, but also in other sectors that mental health, or which blocks mental health or advances in mental health? What would you say? What are some of the key features, key evidence you've come across?
Yes, thank you, Alex. We've been saying, right, mental health and psychological well-being, how they are developed and how the context, Craig mentioned, influence that. And then we also know how the risk factors and protective factors are particularly relevant for that development of the mental health across the life course, and particularly the first couple of decades, right? And so that's when it is key that the right things happen at the right time in the right context. So when we came up with this World Mental Health Report that is on mental health in general, it's not just on youth, but when we look at the challenges, one of the first challenges that the budget that countries allocate to work in mental health is extremely limited. We are talking about 2% of the health budget going to mental health, of the government health budget going to mental health. And we don't even know the portion that from that budget goes to youth mental health because scarcity of data. So that's another key challenge, right? It's very limited information that is available. And the other issue is that when we look at personnel, for example, the scarcity is again huge in general for mental health. And when talking about youth mental health, there are 3 mental health workers per 100,000 population, mental health workers on any kind of profession that could be engaged in mental health. So there is you are welcome to come with or to close the door. And yes, the resources in terms of human resources are very limited. So if we want to have countries working on promotion, prevention, and resilience, and respect human rights, and quality of care and treatment, you need people that are engaged in working on that, and that is also missing. And then when now we hear a lot about the potential of the digital world that has been developed, but that also divides, right? Not everybody has access to the digital care, so that's still something that is a big issue, a big important issue. And then the third area would be about the quality care, the quality human rights based that is not they are available for everybody. And the fact that in many cases and in many contexts, the quality is missing and the care offered is seriously outdated, that's then further generates stigma among youth, and then limits perhaps any interest of youth to seek for health. I mean, if in many contexts, the only care available is located in a very negatively connotated institution, nobody would like to go for help, to reach out to get the help that might be there. Definitely all these limits and barriers in terms of access are changing and are influenced by the local context, but I suspect my colleagues will talk more about the social determinants that are very, very clearly impacting mental health and the access to healthcare. So I would stop here with this introduction.
Very good, Deborah. I think that's the penalty Crick is waiting for, so he can kick and run. Crick, the next question goes to you. You've worked extensively on determinants, specifically on the social determinants of mental health, not specifically only for young people, but also more broadly. What are the key drivers you have encountered in your various research works?
Yeah, thanks very much, Alex. So as part of the Lancet Commission on Global Mental Health and Sustainable Development, we conducted a large umbrella review. It was a systematic review of reviews, and I think we included around 289 reviews, really trying to map out the broad social determinants of mental health at a global level. And we essentially developed a framework which classifies these social determinants into 5 main domains. So the first domain is the demographic domain. There's the economic domain, the neighborhood domain, which refers to the characteristics of a neighborhood or an area that one lives in, over and above the characteristics of the individuals who live in that neighborhood. The environmental events domain, which includes, for example, natural disasters related to climate change or war and conflict. And then finally, the social and cultural domain. And within each of these domains, social determinants exert their influence on mental health across the life course, often through a combination of what we identified as more distal factors and then more proximal factors. So, for example, if we take the economic domain, within that domain, the effect of economic recessions exerts its influence on the mental health of individuals, say of young people, through its effect on employment prospects, income, food insecurity, and so on. So it's often a combination of these distal and more proximal factors or social determinants that lead to a particular mental health outcome in a particular individual. And what's really important with all of this is the life course perspective. So the key developmental stages, which are really important to consider when we think about social determinants. These are stages in which social and economic factors really have a very powerful impact. And these are mainly pregnancy and early childhood development, adolescence, and then very importantly, old age. So when we're thinking about opportunities for interventions from a policy perspective, it's very important that we map out these social and economic drivers, and we map out the potential mechanisms which we could target to try and reduce the adverse impacts of these social determinants, or indeed to try and address some of these social determinants directly in order to improve the mental health of populations. And this perspective is really important because we know that providing treatment alone will not help us to significantly reduce the global burden of mental health conditions. We really need to engage much more in promotion and prevention and to address these social determinants.
Thanks, Greg. Deborah, you want to correct?
If I may add something, is that we the need of investment in all this area of work if we want to overcome the challenges that I mentioned, but also to look at all these social determinants from the angle of what can be done. And so that is something that we tend to not explicitly mention because it might be obvious for some, but it is not. More investment is needed in each one of these areas in order to overcome those challenges and get closer to a real impact on the social determinants.
Miranda?
Yes, just to build on, there's really helpful interventions from both Deborah and Crick. I think one of the issues, one of the things that hold us back as a community is this artificial division between social and biological, psychological and social, psychological and biological. Mental health is an absolute tangle of biological, social, psychological factors, economic factors. And unless we recognize that and start to be really serious about understanding the interplay of that, we're caught in these political wars that are not helpful to advancing this at all. And actually, that same question has to be asked of everything. What can we do to change things? And whether that intervention is at the social level or the biological level or the psychological level, any of those may be route through whatever the determinant that originally caused it was. So I think there's a seriousness that we are ready for now as a community that other health areas already have, that I think mental health has been held back in some ways by us all being so under-resourced that people are just battling to say, look, just do what we can now, don't worry about trying to understand it more. But I think we're at a moment now in history where we can say, no, we want to take this seriously. You wouldn't accept this for cancer care. You wouldn't accept this for TB care. We need things that are going to be really effective and that take into account all those factors and don't artificially silo them.
Yeah, maybe just to add that I think as an aspect to this conversation that we talk a lot about the social determinants of mental health and the responsibility of our community to respond to them, but I just want to maybe make a distinction that where the responsibility lies is at a systemic change level, and advocacy and governments have the biggest role to play in that, and that too often the onus gets put on the individual to deal with and address those systemic level issues. And just to say that we need to really make sure through our advocacy and efforts that the onus is at that systems level, not on the individual. Thanks.
Very good. Thanks a lot. We continue with you, Anne. Just take a bit of water and then we continue. UNICEF, you're working in multiple, as WHO does, of course, in settings, but you're also specialized in fragile contexts. So what are some of the specific challenges you would, probably contrast to other settings which are more stable, that affect young people's, adolescent children's mental health in those fragile contexts?
Yeah, thank you. So young people and caregivers face such an increase in challenges in humanitarian settings, from being on the move to perhaps spending nights in bomb shelters to fractured social relationships, education. The list really goes on, and it really takes the social determinants conversation to another level. Really can't be ignored in humanitarian settings. So I think someone mentioned that 1 in 5 people will be diagnosed with a common mental health problem in a humanitarian setting, but everyone is really affected in some way. It's not just about diagnosis. And it's especially important when we're thinking about young people to intervene early, as severe stressors on young children can really have lifelong impacts on brain development. But these threats to children's mental health in an emergency can be mitigated through supportive family environments and community supports. Lots of other ways too, but I'll focus on those ones. That's why it's really important to include parents and caregivers in every mental health support for children and adolescents, as well as having community interventions that are across different sectors. Maybe as a side note also, when I say community level interventions, I'm not talking just about individual care provided in the community. I'm talking about community-led, community-driven interventions with community level outcomes. So because these are some of the most promising approaches, especially around including children and caregivers, we're working on the one hand to create a new intervention along with WHO, a psychological intervention aimed at younger children that includes parents and caregivers at the center of the intervention. The idea here is that there are lots of different evidence-based treatments right now, but none for that younger set. Similarly, in any community, especially in humanitarian settings, we'll always be saying, if you find someone who needs more specialized care, a child, refer them to more specialized setting. But there's no evidence-based intervention right now at a global level for children that includes caregivers as well. So we're very excited about that. And then a community level intervention that we're working on also, just to quickly mention, is working along with MHPSS.net to develop a contextualized package for how to co-create with the community a community level intervention, because settings are so specific, and so any community level intervention you do by definition has to be totally different from the other community because they have lots of different needs. So this will be a package to help support communities and how to make it contextualized to their needs and create it together. Maybe just one last point that you mentioned, if this differs regionally, and the answer is absolutely yes, and it has to do with the same answer on community level interventions. Because while mental health problems manifest in remarkably similar ways across cultures, the way people deal with those problems and find meaning in the solutions are really, really different. So this is why it's essential to involve young people and their families from the very beginning in any sort of response or intervention for mental health. And then maybe just to mention that within those the emergency settings, that it's important to focus on some specialized populations, especially children associated with armed forces and armed groups, unaccompanied and separated children, children and youth affected by gender-based violence. These are really important populations to focus on in a humanitarian setting if we're going to reach those who need it most.
Thanks, Anne. Now I think it's you mentioned the regional perspective. We zoom into some of the country context with Iman. What are the challenges you face specifically in Egypt to basically advance youth mental health?
I think in Egypt, like in everywhere, as mentioned, yeah, you mentioned the lack of human resources. There is a huge gap between the need and the actual services provided. So, and also we have the problem with the stigma, the accessibility. You know, although we have a few number, also the few number is in the big cities, not in everywhere. So people in rural area can't find a specialized service. And also, if we're going to talk about how to interact with the community, this is not well systematized. You know, the interaction between the system in the governmental body and the other NGOs and the people who's working in the community, this is not very well established. So there is a gaps, and there is some people are more lucky than others because they have the access for the service and other not. Also, when, for example, when COVID happened, we was lucky in Egypt. We was 2 months later than other countries. So we had the chance to learn from the other countries' experience. So when we talk to our colleagues in other countries, what to do with the children and adolescents and how we're gonna deal with our clinics, and they said, go for telepsychiatry. At that moment, we don't have any experience with telepsychiatry. We don't have the the connections, the internet, everything, and also the people. We are working with different social classes, especially in rural area where people are freaked out. What? You're gonna call me? Well, I don't have, I can't work with the internet, and they become very afraid to go for this. Actually, we learned that there is no one solution can be applicable for all. And the challenges, it's maybe the same everywhere, but I think the solutions will be different from one side to another. And I think when there is a need, there will be a service, but sometimes it's not in the formal way, it's in collateral systems. So one of the challenges is we need to understand the services in a different way according to every site, and to learn more from our community, what their needs and what is provided and what's missing. I think this is the main problem. We go for answer, not for the questions, usually. So one of the major challenges is that we are lacking the systematic collaboration with different sites inside the country, you know, the collaboration between Ministry of Health, Ministry of Education, Ministry of Social Welfare, and usually when we are talking about mental health, as you said, it's not usually the priority in funding. Mm-hmm. Especially if we are talking about subspecialty, we are not talking about all mental health, we are talking about youth mental health, which is just a part. So funding is still a problem. So I think it's everywhere, like have been mentioned, and implementation research also is very helpful in this area. It's make us understand more how to overcome these challenges.
Can I just ask, when you referring to not so systematized way of, you know, implementing, is that only between ministries, or would you include other forces in society that also actually want to advance mental health, youth mental health, but probably coordination or guidance is not sought? Is that also the case? Or
Yes. Because I think in Egypt we have a lot of international and national NGOs and bodies that are working for mental health, but as I said, they are not coordinating together. So although there is resources, still the outcome is not the same or as we are expecting with all these resources because the lack of coordination.
Before coming to Miranda to close that first block, I would ask Manvi, pull you in first. you of course have encountered different mental health issues around yourself, but also you know the situation in India. So what do you think, through your own experience, what are the key challenges India is facing in terms of addressing youth mental health issues?
I think in terms of youth mental health, one of the major challenges that India faces is a lack of an intersectional approach. Because when we're speaking about youth, young people, and it's in all ways, like it's my friends, it's on a global level, it's on a regional level, on all levels. There's we need to get out of basically the one size fits all approach, and we need to have a more intersectional approach where we address issues like intersections like people who identify from the LGBTQ community and who may suffer from mental health conditions or mental distress, because we know that is one community that faces all kinds of stigma. People who are refugees, people, and there's also different intersections in health, like a person who maybe suffers from diabetes or TB, and they might also suffer from mental health conditions or mental distress, and how do those two tangle up, and what does that lead to? So I think lack of an intersectional approach is definitely one, especially in LMICs. Another one would be a tokenistic approach. I think there are definitely a lot of changes happening. There's definitely a lot of initiatives being, that are taking place, but a lot of them are just ways to either gather votes, gather public support, and just to have, they're just for vested interests and not for public benefit, not for the benefit of young people specifically. So I think lack of an intersectional approach and a very, very tokenistic approach are basically two of the main mental health challenges to mental health, specifically in India, specifically to youth mental health, and specifically to low and middle income countries.
I think we're coming back to that in the second block. What would be effective action for you that is not tokenistic? Yeah, go ahead.
I also wanted to add that whatever I said to challenges is basically, it would still have some amount, like, if you or I or anybody on this panel or the audience, if we are sitting here, we are privileged in some sense to be sitting here. So when I give my views on that question, when I give my views on the challenges, that is somehow that is somehow influenced with the privileges that I have. So there's a lot of dusty corners that we still haven't touched. So that's just something I wanted to make sure I add.
Very good. Thank you, Manvi. Miranda, I think that's now we're coming over to the second block, but you've also conducted extensive research. And what are the evidence gaps, or through the evidence, what are the key challenges you see that policy, further research, and also practice need to address?
So I guess building on what people have said, we've got this real challenge of how do you develop effective interventions that recognize people's individual needs and are personalized, but are generalizable enough that you can identify groupings that they'll be most effective for. And that challenge is something that we are all very concerned with. At Wellcome, for example, we're about to launch a big funding call for researchers, just sort of put out a plug for all researchers in the room to apply for, where we want people to come up with their best ideas of how you can identify different groups, that sort of intersectionality that Manvi was talking about, to try and target treatments more effectively. And that's one of our big research opportunities and challenges that we have. And I think where I completely agree that in order to do that, and something again we are committed to, I think everyone on the panel is committed to, is how can we work with those most affected, those people who have lived experience of mental health problems, who help advise and design both the projects we're doing and what's meaningful for them, because we do recognize that context is so important. So with mental health, it is all about trying to co-design the research and the practice and the policies with lived experience advisors at the heart of those sort of work.
Thank you. Okay, so I think now we're getting to the next interactive part. And actually Miranda asked me before, do we know who is actually mental health specialist or who works mental health? Probably we can just ask that question, who's working in that space or has worked Can you just lift arms to see? Well, there's quite a few people who are interested in the topic, but not necessarily working in that area. That's very encouraging.
We are not just among converters.
That's what Miranda wanted to see, I think. So open for questions, either here in the audience or online. I see 2 hands in the middle. If you just want to pass on the micro. Or is there any question online we can? Here we have them. Okay. So, yeah, please go ahead. You go ahead, and the speakers probably look at these questions as well, and we pick one. Please.
My name is Zafar Khayyat. I'm pursuing Master's International Health at Charité. So what I want to say, as we all agree that there are a lot of misconceptions around mental health, especially in low and middle income countries. And these misconceptions are the biggest challenges in the way of solving these issues. So my question is, how effective are the international measures or the international plans to solve these problems? In other words, like if some governments themselves are still underestimating or sometimes ignoring mental health issues, how would we expect that the individuals or the small organizations' efforts would be effective on the long term?
Mm-hmm. Anybody you want to give the question, or should we just pick? Okay, no, okay. I don't know, Deborah, Iman,
Yes,
you too.
Who has more time to think the answer? Because this is very difficult to answer straight away. I work for an organization whose main partner is the Ministry of Health, right? And we have ministries of health from the 194 countries that are part of the World Health Organization coming to WHO once a year to decide on the priorities. In 2013, they thought that mental health was a priority, and therefore we came up with a global action plan on mental health that they agreed on, and that has clear objectives and targets and indicators and what to achieve. Now, then in 2019, they say, you know what, we did not make it so far, so we will extend it to 2030, and we still have that action plan, but that's not enough, because that's somebody coming to the main office and a few people looking at the document, agreeing on that, and then not necessarily implementing. So recently, a couple of months ago, we launched the World Mental Health Report, which I invite everybody to read. It's Transforming Mental Health for All, and it is written for policymakers, but people in the ground and it has a lot of stories and a lot of examples of what can be done to contribute to that process, to make sure that the understanding is there, the information is there, and that we also give some hints of what can be done to change the current situation, and also involving people with the lived experience and making sure that we give some also suggestions on how to bring up those interests and that. So I don't think it's one way only, right? We work on one direction, and then Manvi and many others work on another direction, and then the research contributes, and then the organizations that work, and we all need to do more in order to get to that level of information where the individual and the community and the governments all agreed that this is an important area that requires more attention, and that there are things that could be done tomorrow morning or this afternoon to change the situation. Long answer, but I don't think I could come up with a shorter one and more straight.
Iman first, perhaps, and then Manvi.
I think the stakeholder and the policymakers are part of the community. They are reflecting what the community condition, and awareness and stigma always there. There is a stigma, and we are trying to do awareness, and to go for our target, we need to work and work and work. And the misconception no individual action can be done to change this misconception. So advocacy should be working on all levels, working on the community, working on the high level of stakeholders. And, in my works, I learned that the real buy-in is coming when they started to invest by their time. And when they are more convinced, they start to invest money. So misconception to be changed need time, need efforts, and there is a change, but still not satisfactory. No one things can be done to help this, I think.
Manvi?
Thank you. I think all of those are really great points, and especially seeing, so many words about how lived experience needs to be involved is really, really encouraging. Just one thing that I wanted to add to Deborah's point was that it's very important to involve people with lived experience, not just as consultants, but in leadership positions as well. So, I think when they're in leadership positions, they automatically hold more power, and that automatically, because they have been through it and they have lived through it, so they will be better able to address and eradicate all the misconceptions.
Thank you. There's one pressing question here. Apparently, if you look at that, dear speakers, mental health issues among healthcare students. Any suggestion how to address that situation in medical schools? Anybody volunteering? Anne?
I could speak maybe a little more broadly to caring for the people who are providing the services in general. So this would include medical students. So I'm sorry if I won't get as specific strategies for medical students, but I think that this is one of the biggest things of our time right now, is making sure that in every intervention that there's also staff support for those providing care. And that extends across all probably levels of medical care, but I'm involved in mental health, so I'll speak to that. So we recently have just launched the minimum service package, and there's a section in there that is saying that as a very minimum service, this isn't an extra, this isn't a nice to have, you must provide supports for the staff that are providing services themselves. And that also has to be through the HR department. We can't rely on the other mental health care providers to be providing services for each other. It has to be a part of the systems approach that necessarily in any implementation setting, we have automatic supports for time off, for mental health care for the providers, for decent pay, decent hours, all of these things as a part of the impact on their ability to provide decent services. So I hope that addresses it somewhat, although broader.
Thanks, Anne. Miranda?
Yes, I also want to take a broad view on this, and I suppose wants to reflect on the fact that trying to work out what are the best interventions is still something which is, I think, as Deborah said, a bit of a jigsaw that we're trying to put together. And we have to make sure that we're not drawing on assumptions that are simply wrong from the science. So if I can just give you a couple of examples that may be of interest to people. One example is research we're funding at the moment, which is by a very innovative professor in Sweden called Emily Holmes. And she's looking into a very radically new intervention for healthcare workers who have post-traumatic stress disorder and have intrusive images coming into their heads. And this intervention is interesting because it doesn't involve a therapist. It doesn't involve medication. It involves 15 minutes supported play on a particular digital game, Tetris, which is available to everyone. And it's based on neuroscience, which is about how you lay down memories and how you break memories. It isn't a catch-all answer for everything to do with anxiety and depression. It is a specific intervention for stopping intrusive memories. We don't know whether it works yet. The trial is still being done. But that for me is an example of where we want the rigorous science to go, which may be very different from what feels intuitive. So if I give my second example of research that we've just had published, that we funded, which was research into mindfulness in schools, which was for school children, but could have equally been applied to other groups, and where they found that actually doing mindfulness in a very rigorous way, in a very good way, did not actually prevent or address anxiety and depression in the way they had predicted. And those are the sort of science we need if we're actually going to work out what is best before we throw lots of things at people. And I think this is why I want to give fantastic credit to both UNICEF and the World Health Organization, who are really trying to rigorously look at the science, look at it for workplaces, look at it for schools, look at it in places of trauma and in places of crisis, and say, okay, what does the science actually say? And I think for those of you in the room who aren't in the mental health field, really look at those advice and guidance groups carefully, because there are so many advocates in this field pushing a particular agenda, and these sort of organizations are not. So I suppose just that is a real something I'd like you to take away from you.
Thanks, Miranda. We take one more question, the gentleman who was wait, and then we need to move on. Miranda, if you can just probably look at the third question and integrate it later on when we talk about research priorities. Because the second we've answered, so I'm not coming back to the second question. I still insist there's the young person on the panel. Gentlemen.
Thank you. First of all, I'm from the German Medical Students Association, and I want to address a topic which was only barely spoken in this panel and spoken of in this panel. What I think is very problematic, and which is a core problem of all this mental health discussions, is mostly the whole stigmatization in the community, in social circles. And just to give you a quick example, if someone broke his or her arm, depending on the story behind, of course, but no one would think bad of this person. But if you have a depression, that's a whole different story. And that's what I want to, that's directly connected to my question to all the panelists, and especially to those working in bigger organizations, if there are any concrete steps to get rid of the stigmatization. And if yes, could you maybe be very specific, please?
Deborah first, and I see also Crick has got his hand up, but Deborah first.
I was about to say something when Manvi talked at the beginning, and I did not have the time, but I was thinking that it takes courage to say, I have a condition of any kind in mental health. And as I was smiling when you were talking, because I use always that example. If somebody, I say it in the office, I live in Geneva, Switzerland. If over the weekend you hurt your leg because you were hiking in the mountain, you will come on Monday, I will say, oh, I broke my leg because I was hiking and I had such a wonderful time, but then I feel like hurt. If you were on Sunday lying in bed with depression, you won't come on Monday and say what happened to you and so on. Anyway, so I think that speaking up is the way, and there have been changes that a few years ago, not 50, 3-5 years ago, we will not have someone sitting here in front of everybody saying, I have such and such issue, or my family member, or something like that. So we are moving forward. We have numerous campaigns. I just have one from a few years ago that it's in my phone. It says, let's talk. It was a campaign about depression called Let's Talk. And these kind of initiatives that are many right now nowadays are also useful. In many developed high-income countries, you have a lot of so-called celebrities talking about mental health, and that, or influencer, and that is having also impact in a changing mindset. I think that's the way. I am not aware of any other way. I mean, the accepting that having a mental health issue is not something to be ashamed of, or accepting that someone with a mental health condition is not somebody to blame for it, or to judge because of it. It is a process, is changing. Maybe through these initiatives is that we can move a bit faster than what we have done in the past.
Thank you, Deborah. Crick, please.
Yeah, just to add, thank you so much for that really important question. The whole issue of stigma is really an essential issue in this field of mental health that we should be thinking about more. And just to mention, just this week, the Lancet Commission on Ending Stigma and Discrimination Against People with Mental Illness was launched. And it brings together the evidence on what are effective interventions for reducing stigma against people living with mental health conditions. And one of the key interventions is really around social contact. So people having contact with somebody with lived experience, being able to share that experience is a pivotal mechanism for reducing stigma. So the more we talk about mental health, the more we share our experiences, the better in reducing stigma. And there are a number of national campaigns that have been shown to be highly effective in reducing stigma. I just wanted to point out one really exciting intervention, and it's a trial that's going on in Nepal at the moment, being led by Brandon Court. It's called the Reshape trial, and it's based on some work that was initiated as part of the PRIME program, which I was involved in, the program for improving mental health care. And essentially what it does is it introduces people with lived experience of either depression or psychosis or alcohol problems into the training of primary healthcare workers in primary care clinics in Nepal. So in addition to the standard WHO MHGAP training, which provides clinical skills to non-specialist health providers, what this Reshape trial is doing is testing the effectiveness of also introducing people sharing their experiences and allowing their stories to be told in order to influence and try and have an impact on stigmatizing attitudes among healthcare providers. And from the pilot trial, the results are really encouraging, not only in terms of reducing stigma, but also improving diagnosis and care provided by non-specialists. So I think the more that we do to integrate stigma reduction into a whole range of interventions, the better. So thank you for that.
Thanks, Craig. Manvi, very shortly, and then we move to the last block.
Definitely. I think another thing that besides those with lived experience, I think there's other things that other parts of the society can do as well. And that is, from a very young age, we do not, when we talk about education, when we talk about the books that we read at school or at college, they do not generally tell us about the social factors that affect mental health. And when we do not learn about that, when we do not learn about the general misconceptions about what a certain mental health disorder or mental health is in its real sense, we automatically get influenced by what the media shows. And the media in itself oftentimes, has very stereotypical views about mental health. So I think instead of, besides also along with people speaking up about their own experiences, I think the media, the education system also needs, changes and at granular levels. So.
Thank you. Miranda.
Just to add one thing on that point, I completely agree with everything that's been said. And I was just trying to look on my Twitter feed out. There was a very impressive tweet recently from, I think it was from the Surgeon General of California, who was saying that she had bipolar and that she was functioning. And it was, these things make a big difference. But I also think we should learn from other health conditions. HIV and AIDS became non-stigmatizing when we had a way of treating them. When we have effective treatments for mental health, a lot of this will go. So I really believe in anti-stigma. I really believe we need to do things about stigma, but that will not in itself solve the problems that are holding people back in life. We have to try and really find better solutions for those problems, and that in itself will address stigma.
So that brings us really to the second block. It will be a bit of a speed date because we've got 30 minutes left and I really want you to speak up. So first one is Slido again for a bit of interaction. Next and second question. Well, we've heard a lot about different challenges. We've moved actually also into action questions already. So we've heard different examples of what can concretely be done from basically all of the speakers. But in your view, and your experience, or what you think, what type of action is required to address these challenges, some of these challenges you've heard, so it will be a word cloud as well. While waiting for the results, we'll have a speed date. So everybody, including Craig, really short, 1 or 2 minutes. You've given already examples, but what are some of the key approaches, key policies, key innovative strategies you've encountered, you've heard of, you've developed or implemented yourself, which you would like to see to go to scale, or which you would like to further develop?
Okay, top 3, yeah?
Yeah.
Okay. So,
or 2.
or 2. I'm going to try and get in 3. Okay, so first I would say workforce development is essential as an overarching systemic approach. So the overwhelm of need globally way outpaces the number of workers we have to provide those interventions. So this is a critical gap, especially in humanitarian settings. I think it's also essential to build up the tertiary levels of education and mental health care in those settings globally, in low and middle income settings and humanitarian settings, as a way of decolonizing mental health and flipping it. We're not going to need to be sending mental health workers from Europe to every humanitarian setting if we already have good sources of education at the places where we need it. I think a good way that we're trying to address this is through EQUIP, which is right now a approach that we're working on along with WHO, competency-based assessment, not memorizing a test, being able to demonstrate that you have qualities for mental health care in a healthcare setting and across different settings, not just healthcare settings, education, child protection. Also, we're creating a global course for frontline workers in humanitarian settings focused on child and adolescents. And that is actually rolling out this month, which is very exciting. Number 2 is multi-sectoral approaches. Young people are not one-dimensional and can't be reached through only one setting. So we really need to have mental health care that is across different sectors, education, health, child protection, but lots more. WASH comes to mind if you're familiar with these different words. How can we make sure that different sanitation procedures include different things about mental health? We can incorporate it everywhere. The minimum service package that I mentioned before is a great way to do that. It actually gives you a checklist of what actions you need in different sectors to be effective and comprehensive. And then also the final thing I think I'd say is that mental health is political. It must be intersectional. Thank you for mentioning that to start us off, Manvi. But we really have to push beyond just looking at poverty and look into other structural inequalities. And as I said before, it's really hard to do that when you're only looking at it from an intervention perspective. It has to be paired with advocacy. It has to be paired with financing. And really take off the onus on the individual and give the responsibility to the systems. Thanks.
Thanks, Miranda.
Right, so I'm going to try and wrap up that question in 3 at the same time.
I'm coming back to you on the research priorities as well, but you can't just
I'll
wrap it into one.
I'll wrap it in. So in terms of my first, I think, opportunity here is that we need to have rigorous science based on the social dynamics as much as on the biological or psychological dynamics. So, for example, there was a question about how can we fund research that also looks at issues of discrimination or impacts on mental health. We have an example, for example, where we are looking at a data set in the UK to try, well, we have funding someone, we are not doing it. We are funding someone to look at a data set in the UK to look at the impact of extreme evidence of stop and search, which is more likely with people of color, and what that impacts on their mental health years later in terms of looking at longitudinal data. So I think we've been, again, I would encourage people to think about research questions that look at these issues. They are eminently researchable. There is a sort of idea that somehow they're less researchable. They're not. You just have to think, what is the research question, and then ask it with the same sort of rigor. The second thing I think is that we need to really find a way to harness the power of digital. I appreciate not everyone in the world is digitally connected, but increasing numbers of the world are. And there are real opportunities we can do here. And there is a real tension here about finding the right balance between over and under regulation, and between demonizing everything that's digital and in a way not using it then as a power for good. So I think finding the right balance between digital in terms of different ways it can take things forward. And then I think the third is the thing that's come out of the theme here and so often does. Unless you involve people with lived experience from the start, you are designing things that are designed to fail because they are not made for the people who are going to use them. And the same would be true of policymakers. Policymakers should be working at a much earlier stage with researchers and others saying, what is it actually feasible to roll out? What is possible? And then thinking about how to design science that will help move towards that.
Thanks a lot, Miranda. Iman. And then we come to you, Craig, in between. Iman.
Okay. I will talk more on overcoming the challenge. One of the projects that we are worked on in Egypt is school mental health program, which is WHO program. And when we started to implement this program, we learned more about the implementation research, and this makes us see in a different way. It makes us to think about shifting the tasks, because we have a little number of specialized personnel, and how to use the human resources in the Ministry of Education to spread the knowledge about the mental health, and this will decrease the stigma. And also, we are in Egypt, so we have a psychologist inside the school. They are educational psychologists, but we are trying to modify their job description to help us. So give them training for a clinical, and also give them the school mental health program. And we do like psychosocial centers inside the schools in some cities, which has no services, specialized services. It's like an informal primary care centers specialized for mental health. And this was very, the feedback was very good, you know. Actually, without increase the burden on the system, we have a space that's seeing every year more than 1,000 child without stigma, because it's inside the school, in the normal environments of the children. And also the parents was involved by parents programs. They give them some sort of education about parenting, and also try in these centers to do some activity for talented children in arts, in music, not to be stigmatized for children who has problems inside the school. So I think to overcome the challenge, we need to shift the tasks. We need to work on the stigma in the community by people who are working in the community naturally, having the same language of the people, not the specialized personnel. And the final things is to find the way for coordination between different ministries and sectors to do this comprehensive work.
Thanks, Iman. Trick.
Yeah, thanks very much. Thank you. So just to build on some of the comments so far, which I already agree with wholeheartedly, just one example of work that we're doing is to combine an intervention to address poverty with an intervention to address self-regulation in adolescents. So really trying to more rigorously address social determinants alongside addressing psychological factors that increase risk for depression and anxiety. The study is called the ALIVE study, Improving Adolescent Mental Health by Reducing the Impact of Poverty. And our hypothesis is that poverty has a direct impact on adolescents, increasing risk for depression and anxiety, but it also has an indirect effect through its effect on self-regulation. And so we're designing a selective prevention intervention, which both addresses some aspects of poverty, for example, through cash transfers and financial literacy and savings groups, together with an intervention to strengthen self-regulation in adolescents. And the study is happening in Colombia, South Africa, and Nepal. We're in the very early stages, but we'd be really interested to hear comments, questions from people that they might have on this. So that was the one suggestion, is really trying to integrate our earlier conversation about social determinants into how we address adolescent mental health from a prevention, promotion, and a care perspective. The second point I wanted to make is that there is already quite a wealth of evidence on school-based interventions to promote mental health and to prevent mental health conditions. And I was privileged to chair the WHO Guideline Committee on Prevention and Promotion Interventions. This is part of the Helping Adolescents Thrive initiative, which is a joint WHO-UNICEF initiative. And there really is quite compelling evidence to scale up prevention and promotion interventions in schools. And this includes not only providing social and emotional skills to adolescents at an individual level, but also trying to address classroom and school climate, for example, by reducing bullying. So these are, I think, some really exciting potential interventions. Some of them can be taken to scale now. Some of them are in the early development stage. Thanks very much, Alex.
Thanks, Rick. Deborah.
So I mentioned earlier that we just came up with the World Mental Health Report, and there we have 3 paths for transformation, we call them. So if we think about those 3 paths and focusing on youth mental health, one issue to highlight is that the importance of, we believe we must deepen value and commitment, in particular now for youth mental health. Mental health is important. That's the value of it doesn't matter whether it was mentioned at the very beginning, whether you have a mental health, health condition, a disorder or not. mental health has a value and as such needs to be considered, and therefore the investment and has to be also there, the commitment to invest in that, whether it is in financial resources, human resources, etc. That commitment is needed, and the budget needs to move from the traditional way of institutionalized mental health care to community settings and some of the issues that were mentioned earlier. The second one is that we must reshape environments for better youth mental health. And if we focus on the health in the health sector, that is the area where we work mostly, still the issues of intersectoriality that were mentioned earlier are very important. We need to pay attention to parenting, particularly parents and carers of adolescents with any kind of challenges that they may encounter. The initiative that was just mentioned by, I pointed up there, Craig, when referring to you, that was mentioned by Craig, that is the Helping Adolescents Thrive. That's an intervention in school, and school for all those kids in the world that have the opportunity to go to school is a crucial environment where to intervene. And of course, all the interaction between mental health and any of the other conditions that was also emphasized earlier. And the third area is that we need to also strengthen mental health care. And there are interventions that are based on evidence. And when Miranda was talking before about making sure that whatever we promote is having the science behind, I was recalling my own frustration, if we want, when I read the final document of the Helping Adolescents Thrive guidelines, and you find that for a lot of issues that are being promoted out there, there's no evidence. And the same that we just heard about the mindfulness project, right? Same is for a workplace mental health. You read and you say, oh, now we will come up with these guidelines that will tell, and then you find that there a lot is still not known. But there are those interventions that work, and we are coming up, it was mentioned earlier also by Anne, early adolescent skills for emotion. We did some trials and it seems to be working, and they are low intensity psychological interventions that can be delivered by peers and by non-mental health professionals. And so the possibility to expand and scale up care for people in need is huge. It can be delivered in groups, individually, and so there are things that could be done better right now. Thank you.
And Manvi.
I think all of those are equally important, and also with everything that we've addressed earlier. But I'll just randomly pick two, and those two would probably be, the first one would be, like I said, integrating education and mental health. Like, I haven't had one book in my school life or college life that talked about the social determinants of mental health. So I think that is definitely important, not just because it helps us fight stigma, but also because it helps a young person identify what is happening with their mental health, where do they need to go if they want to seek help, and what are their own rights, their own duties. So I think that's definitely important. The second one would be obviously involving people with lived experience, especially young people with lived experience, because they get along with themselves a plethora of diversity, and so I think and when I speak about involving those with lived experience, I do not mean treating us as lab rats or as simply subjects. I mean that I do not mean that when the entire plan has been laid out, when there's already a blueprint in place, you get us and you ask us that how does that look and what changes can we make to it. We want to be involved right from the moment where you have the blank paper open and you ask us that how should we start and how should we build upon and how should we end. We want to be involved at every level, from leadership to the lowest positions. So I think those would be my top two suggestions.
Thank you, Manvi. You've already answered the last question for today's panel in terms of youth participation, but let's look at the slide results if we can, to mirror that a little bit with what has been shared by the panelists. And then I just ask you, whenever you think anything resonates with you in either direction. I think effective treatments, very big, Miranda, your point. And probably linked to the element you highlighted, that is probably not an exclusive question to do research and work on effective treatments and the axis, and also more the social determinants. Financing, Deborah, all of that, all of the drivers we may identify and the good solutions we have need to be funded somehow. Manvi, listen to young people, no? Probably it's even more than listening to young people. Probably involves a bit more. Anything else you want to comment on? Anne, Miranda, Iman, Craig, Deborah?
You know, when you say all of the above, that's all of the above when you want to answer. They are all relevant, and the challenge is how to make sure that we, each one in our own roles and positions, can answer to as many of them as we can in an integrated way and not fragmented.
Yeah, Craig, please. Sorry.
Yeah, just wanted to home in on this whole concept of a whole of society approach, because for me, that really captures so much of what we've been speaking about today. We really need a much more coordinated policy approach in which adolescent mental health is at the forefront of a whole range of different sectors, including social welfare, education, schooling, healthcare, of course, but also poverty reduction programs. How, for example, can cash transfers be adapted and developed in a more targeted way to improve the mental health of adolescents? So I think really shifting the policy agenda from one of scaling up treatment services, and this is just something that concerns the Ministry of Health, to a much more broad whole of society approach is really where we need to be going next. And also just to echo Manvi's point, we really need to put young people at the center of this. In our Alive project, it's been absolutely wonderful to have adolescent advisory groups established in each of the research sites, and they are actively involved in helping us to design the intervention and design the study. So this has been a huge contribution to the work that we're doing. Thanks, Alex.
Thanks, Craig. Anybody else? Anne?
Maybe I just mentioned that from some of the things on the screen, and then our colleague here who asked about stigma, and then one of the most upvoted comments being about how we're addressing the mental health of students, medical students. You know, if there are many of you in this room who are medical students who have not yet been involved in mental health work, which it seemed like from the hands that's true of most of us here, then please join us. This is how we're going to have the culture shift, is people getting more involved. And already by being here today, I'm just really inspired by your interest. And so I think by your further involvement and taking that forward in your careers and integrating it, even if you don't become a mental health professional, that's not necessarily what's always needed. But by integrating some of these things and destigmatizing mental health in whatever direction you do go is just really the way forward. So thanks.
Anvi?
Not much to say, I'll save time, but just wanted to divert everybody's attention to the fact that there's also workforce support. When we, especially today in the panel, I think one thing that we definitely forgot and disregarded was that workplace mental health is very important. So, yeah. So I think that definitely needs to be taken care of.
Okay. Please, go ahead.
Universities, about schools, about kindergarten, how they grow up with this. What kind of programs, what kind of research are you addressing to this area? How to grow with this, how to think about that area. I mean, working for a workplace, I'm an occupational health physician, and then what kind of comments that I'm receiving from employees. I'm sorry. So, okay, thank you. So working as an occupational health physician on a global level, many of the comments that I'm receiving from employees are related to how to deal with our children, how to deal with the situation that they are bringing from schools or from universities, the situation that they are bringing from sports activities, how we are addressing those areas. And usually I'm searching about beyond what we are offering for workplace, what we could bring to the workplace to educate them how to deal with those situations. But thinking now how we are addressing those kind of programs within the universities, within the schools, I believe this is an area of action where it will raise the awareness, will raise the way that we are understanding the situation. Thank you.
Thank you very much. Very clear proposal. I think we dropped the last Slido question that would have been around youth participation, but we would anyway ask Manvi again because it was quite much. You started that conversation, but unless we have a speed question and answer, then we can also throw the Slido question. But if you could answer that at least, and you've started already, you know, what you said at leadership level, at lower levels, but what concretely, how would you like to be included or think young people should be included? Where does it make sense?
I think,
where is it key?
Yeah, I think, when we talk about youth participation, so it's probably just going to be the same things, but just a little bit more specific. So, there's a lot of lived experience boards, youth boards being implemented, being launched at so many organizations. And the organization that I work with, that I work at, I'm very proud of that. The Global Mental Health Peer Network is definitely one. They have a youth subcommittee. They have, I'm one of the youngest members of the organization. So I think the fact that those kind of opportunities are reaching young people and they're aware of those opportunities, because a lot of times what happens is that opportunities go and they have a certain focal point where they go and end, and they do not reach beyond that. They do not reach, again, like I said, the dusty corners, or a very diverse audience. They just go and end up with a specific group of people. I think that definitely needs to be eradicated. And the key to youth participation, to better mental health for youth, is definitely, first of all, have the people, that those laws are about in the first place, have them on board with you, and not just listen to them, but again, like I said, it's going to be the same, just a little bit more specific. Have them on board, have a lived experience, advisory board, have a young trustee in your organization, have young directors, young people as a part of your team. So I think that is that I would place as the most important thing.
Thank you, Manvi. Miranda wants to react.
Yeah, I agree with all of that. I just share a bit of a personal reflection. We have as a bit of an indicator when that is working well, when we treat people as colleagues and we can disagree with each other as much as we can agree. So a personal worry I sometimes have is it becomes tokenistic, and we have young people on, the young people speak, we say, that's so amazing, thank you so much for that comment, that was wonderful, and the conversation moves on. And I think we've got to get to a position where those young people are trustees, they are directors, they are equivalent colleagues, and they are equivalently, sometimes they'll win, sometimes they won't win, sometimes their views will be taken into account, sometimes they won't, just like any other colleagues. And I think that's a mindset that we all have to move to. We cannot be a sort of virtue signaling without actual real power. But also, on the other hand, it also means that those young people are very special young people. They aren't just anyone with lived experience. They, Manvi is not just, you are a professionalized person who is bringing particular experiences. And I think we have to recognize that. So it isn't just, as Manvi said, getting someone on the street and saying, I have a focus group and now we've got your views. These are people who are part of our community, who have value to add. And I would also say, always, if possible, have more than one of those young people, because I think it's hard to be the only person. So yeah, that's why.
Thank you, Miranda. Deborah.
Yeah, I cannot agree more with what Miranda said, and I wanted to say the same about involving people with lived experience. Because you invite one person with lived experience in your committee, it doesn't mean that you are paying and giving the role and the room and the possibility and the respect you deserve. It has to be on daily basis that we all listen to who we have around. I'm proud to say that some of these new tools that we are coming up for youth have been developed by, first of all, collecting input from youth, but I know that that's not an everyday issue, and that we do not do enough. I think that, again, also in this field, we are all changing and learning. But again, it's not the one person, and it's not that because it's a person with lived experience will know everything. We'll have the personal experience. If we listen many more, then we will get more smarter inputs, collective inputs, and feedback. So process that we all need to get engaged with.
I got a sign that there are probably 3 or 4 minutes left, so it's quite hard to do a wrap up, but I'll try anyway to pick out a few takeaway messages that are hopefully concrete enough, which I picked up. But please listen carefully, all 6 of you, and correct me or add anything. I think first point was to say we need rigorous evidence. You know, we need to know what sort of solutions we're developing, whether these are treatments or any intervention on determinants and drivers of mental health, for example, including also implementation research. We need to know what works and what doesn't work and why. So that's probably point number one. Point number two that came out quite clearly was we need to work across sectors. We can't just stick with the health system. I think there were various examples, especially from the educational sector, where it is key for advancing mental health of young people, including the question of reducing stigma, creating awareness among teachers, peers, and so on. The third message I would say was around healthcare workers, quite strongly, that we need to work on healthcare workers, also those who are non-specialized, to get more skills at hand to handle mental health issues and conditions. That is certainly number three. Four, again, linked to multisectoriality, but also to the question of structural inequalities that basically then link to mental health, the question of poverty, and that we also need to address in a targeted way some of these elements to have an influence then in a positive way on mental health. And the last one I would pick out came from Deborah in the beginning, came also out here in the slide. It was, well, all of that needs to be financed somehow. So we cannot avoid the question of appropriate financing also for mental health, be it research on clinical research on treatments or social drivers. So that is still the elephant in the room. But I think what we've seen is, in my opinion, quite concrete ideas, interventions that have been tested, that are around, that could be taken forward. So I don't know whether anybody wants to add anything to that. Otherwise, we close in time, and I hope it was inspiring for you as well. Thank you very much to everybody.